Hey everyone, thank you so much for joining us today. I'm so excited for this talk and our discussion. I wanted to introduce Merelise. She is currently a clinical psychology intern at UCLA on the acute child adolescent care track. This year, she's had the privilege of training on multiple hospital services and outpatient clinics, including 4 West, the Pediatric CL Service, the Child and Adult Neurodevelopmental Clinic, and the Center for the Assessment and Prevention of Prodromal States. Prior to moving to Los Angeles last year, she has always lived and studied in predominantly rural areas. She grew up in rural Maine and completed her undergraduate studies in psychology and Spanish at Middlebury College in Vermont. After college, she worked as a research coordinator at the University of Vermont, where she worked with doctors Robert Altoff and James Hudziak on a research program that sought to identify shared biological mechanisms of psychiatric and metabolic disorders. After that, she completed a master's in public health at the University of Vermont, which inspired her to approach understanding in psychiatric and other health disorders from the perspectives of the social determinants of health. She went on to complete her PhD in clinical psychology at the University of Vermont, where she had the pleasure of working in primary care clinics, schools, inpatient psychiatry units, and outpatient clinics. Across these settings, she served predominantly rural and low-income families, which further reinforced the critical role that social determinants play in mental health. In particular, she observed that many families were worrying about where their next meal would come from. To better understand the effects of these worries on her patients and their families, she conducted her dissertation study on the role of food insecurity and the Supplemental Nutrition Assistance Program on family functioning and child mental health. And she'll be presenting these exciting results to all of us today. Next year, she'll be completing a postdoc research fellowship at Maine Medical Center in Portland, Maine, where she will be focused on understanding and expanding pathways to care for rural youth with serious mental illness. So very excited to have her here, and I'll let you take it away.
All right, thanks, Roya. All right, so thank you everyone for being here today. I'm going to be presenting, as Roya mentioned, the results of my dissertation study, which was titled The Effects of Food Insecurity and the Supplemental Nutrition Assistance Program on Child and Family Functioning. This project has really been a labor of love for the past few years, and so it's really wonderful to be able to share it with all of you today. Before I start, I want to point out that I do not have any disclosures related to this work, and most importantly, I want to highlight my wonderful team at the University of Vermont, including my graduate mentor, Dr. Robert Altoff, and Hannah Faring, our lab coordinator, as well as many undergraduate students. They really made everything that I'm going to be sharing with you today possible. So in terms of a roadmap for our presentation today, I'll start out by providing some general background on food insecurity and child mental health. Then I'll dive into the theoretical framework supporting the study, as well as some of my specific aims and hypotheses. I'll then describe the methods we use to test the hypotheses, and then, of course, share with you the results and some of the major takeaways from this work. So starting out with some background. Food insecurity broadly refers to a condition in which a household's access to appropriate, nutritionally adequate food is either limited or uncertain. This can encompass a wide range of experiences, from simply worrying about obtaining food to relying on unhealthy, inexpensive foods to meet a family's caloric needs, to, in more severe cases, cutting down or skipping meals, sometimes up to a full day or more. And to give a sense of the scope of this problem, the most recent national level survey data, which was from 2018, showed that 41 million people, including 12 million children in the United States, were food insecure. To further put that in context, that is more than 1 out of every 10 households in the United States. So these are definitely families that we are seeing in our clinics that are experiencing food insecurity. Unfortunately, vulnerable groups are disproportionately affected by food insecurity, and communities of color, single mothers, folks with disabilities, and rural households sometimes have up to twice the rates of food insecurity. It should also be mentioned that there was really a precipitous increase in food insecurity during the early stages of the COVID-19 pandemic, with some estimates suggesting that between 30 and 45% of households experienced food insecurity during that time. While the rates of food insecurity have decreased since the early stages of the pandemic, evidence suggests that they have not really returned to their pre-pandemic levels, which were already very high. Additionally, during the pandemic, food supply chain disruptions resulted in shortages and increased prices for many common grocery items. However, at the same time, many families benefited from programs that were either created or expanded to help alleviate the pandemic-related hardships for low-income families. So, for example, SNAP allotments were temporarily increased, and federal school meal programs were expanded to make free breakfast and lunches available to all students. State and local governments also developed many innovative programs and initiatives to further provide food and economic assistance to families during this time. So, in terms of food assistance in the United States, generally speaking, the Supplemental Nutrition Assistance Program, sometimes referred to as SNAP, is the largest federal food and nutrition assistance program. However, the design of these programs has been criticized for being disconnected from the realities of the families that are participating in them. So the benefit amounts are determined in accordance with what is called a thrifty food plan, which is intended to be a minimal cost, nutritionally adequate grocery plan, but it relies extensively on the preparation of meals at home. There's some evidence that suggests that in order to make a SNAP allotment stretch for a full month, it would require a family of 4 to spend 16 hours a week preparing food. This is simply untenable for many low-income families in which caregivers are oftentimes single parents, may work multiple jobs that have erratic schedules, and they may lack access to the necessary kitchen or culinary tools. And so as a result, most oftentimes, families rely on more expensive ready-made options, which then results in their benefits running out before the end of the month, and in almost half of cases within the first 2 weeks of the month. So this creates what is sometimes referred to as a feast-famine cycle, where participants tend to overeat when food and resources are available at the beginning of the month, leading to increased food insecurity and reduced intake at the end of the month. So this is all concerning for a number of reasons. One of those is that the literature suggests that food insecurity is associated with a wide range of negative outcomes throughout the lifespan. So more specifically, food insecurity has been associated with learning and behavioral problems during early childhood, anxiety, depression, and school absences during middle childhood, substance use, suicidality, and school dropout in adolescence. And in young adulthood, food insecurity increases the risk for disordered eating and trauma exposure. And very often, individuals who experience food insecurity in childhood go on to experience poverty and food insecurity in adulthood. So, in order to disrupt this cycle of food insecurity and disease, it's necessary to understand the underlying mechanisms that are driving it. And this leads to the primary research question for my dissertation study, which was, how does food insecurity exert negative influences on children's social emotional development? Presently, there are two major pathways that have been proposed through which food insecurity may affect child development. And those are through nutrition and through parenting stress. With regard to the hypothesized pathway of nutrition, it is well established that nutrients such as protein, fatty acids, iron, zinc, vitamin A are all very much needed to support healthy brain development, especially during the early years of life. In animal models of cognitive development, early malnutrition has been associated with numerous emotional and behavioral processes, including the regulation of affect, motivation, cognitive flexibility, and learning. In addition, in severe forms of malnutrition, such as kwashiorkor and marasmus, we do see that there are associations with attentional challenges as well as lower academic performance. However, in the United States, most research actually suggests that there are minimal differences in the diets of food insecure and food secure children. And while this may seem surprising, there are a number of good reasons for this. First, caregivers often attempt to protect their children from hunger and malnutrition by sacrificing the quality or quantity of their own diet. Second, many low-income children are benefiting from participation in programs such as the National School Lunch Program, or which requires the meals to meet national nutritional standards. So for these reasons, it's quite likely that the developing brain would have some resilience to the mild levels of nutritional deficits that most food insecure children in the US seem to be experiencing. This would suggest that nutrition alone cannot fully account for food insecurity, increasing the risk of emotional behavioral problems in children. So the other potential mechanism that may connect food insecurity and negative child mental health is parenting. We know that low-income caregivers experience high rates of stress across numerous domains, and there's limited research really about specifically how the effects of food insecurity affect parenting. There is some evidence to suggest that caregivers in food insecure households do tend to use fewer positive parenting strategies, be more irritable and tired in interactions with their children, and just generally view their role as a parent less favorably. From a theoretical perspective, parenting is also a plausible mechanism to connect food insecurity and children's emotional and behavioral development. In particular, my work was really informed by the scarcity mindset theory, which in essence posits that when a resource, such as food, is perceived to be scarce, humans will tend to direct their energy and cognitive abilities towards that resource. This effectively allows them to manage pressing short-term needs, but inevitably does come at the cost of detracting attention and energy from other important domains of life, such as parenting. I think the most relatable way to apply this concept is to think about what you experience when you have an impending deadline, such as a grant application, and time is really scarce. Most likely, you will effectively channel your attention and knowledge towards meeting the goal of finishing your grant in time. But in doing so, you're likely to not be giving your full attention to other important responsibilities, either other professional responsibilities or personal responsibilities during this time of intense focus. And what we're suggesting is that food insecure caregivers are constantly faced with this attentional trade-off between directing their cognition towards managing food and being present as a caregiver. More specifically, caregivers may be directing their attention towards what we refer to as food-based coping strategies. These are really any behavior that a household adopts in order to adjust to food shortages. In, in the United States, common strategies include things like traveling to multiple stores to find the lowest price, borrowing money, selling personal belongings, and visiting food pantries, among many other strategies that families will employ. And while these behaviors are likely to help mitigate short-term food insecurity, they can require a substantial amount of time and cognitive bandwidth to organize and carry out effectively. And necessarily, that may detract from other areas of life. So finally, I want to point out some of the limitations of previous research on food insecurity. While food insecurity and its negative consequences have been widely studied, there really is very limited research on the mechanisms that may account for these associations. One reason for this may be that existing measures of food insecurity are not well suited to this type of mechanism-based research, as they're designed to assess food insecurity over a long period of time, such as a full year. This can make it really difficult to disentangle the effects of food insecurity from other closely related social problems, such as poverty. Food insecurity at its core is also really about that day-to-day instability and not knowing where your next meal is coming from. The use of broad measures does not really capture that key feature of the lived experience of food insecurity. And for these reasons, I wanted to conduct a study that really captured in detail and with some temporal specificity the daily experience of living with food insecurity. So in order to do this, I decided to use a novel daily diary approach where participants were reporting on their experiences of food insecurity every day over the course of a full SNAP benefit cycle. So now I'll talk a little bit more in detail about how I went about conducting this research. So I sought to recruit caregivers of school-age children, with the major inclusion criteria for the study being that they had to have a child between the ages of 6 and 12 with whom the caregiver lived at least 75% of the time, and that they also had to have some degree of food insecurity within the past month. They also needed to reside in a county that was designated as rural, as well as have access to the internet and a phone that had text message capabilities. So the overall process was that participants were recruited through online social media ads and completed a screener to determine their eligibility. Then those who were eligible and interested were scheduled to participate in a baseline study visit. Following the baseline study visit, they began receiving brief daily text messages about food insecurity, as well as other areas of functioning for the next 35 days. And then at the end of the study, participants were compensated up to $225 for their participation based on the number of daily surveys that they completed. It's also worth noting that the data collection that I'll be describing did take place during the middle phases of the COVID-19 pandemic between March and December of 2021. And notably, the data collection only occurred during the K through 12 school year, so not during the summer. And the reason for that was to avoid any confounds that could be associated with the changes that occur in families' routines or services during the summer months. During the baseline study visit, we ended up conducting this in an entirely remote format, which was not what we had originally planned, but due to COVID-19, this was how we conducted it. Most of these were done via Zoom, but for some families that were not able to use Zoom, we were able to accommodate telephone visits as well. These visits were probably the most onerous part of the study procedures, and it did last about 2.5 hours, and it involved informed consent and completion of online questionnaires and computerized cognitive tasks, which were intended to really comprehensively assess the caregiver and family's functioning. Then, beginning the next evening, participants began receiving daily surveys via text message, which was automated using a third-party program that was called Mozio. On the right is an example of how these surveys appeared on the participants' end. And they were asked to report on their experiences during the preceding 24-hour period. In general, the surveys were brief and took less than 10 minutes a day to complete. And so the results that I will be presenting are based on the following measures. There's quite a few measures that were used in this study, and so for the sake of time, I won't go into detail on each of these, but generally speaking, at baseline, the household's food insecurity during the past year, the child's emotional, behavioral functioning, the caregiver's physical and mental health symptoms, as well as their cognitive functioning were assessed. All of these measures were intended to capture more stable trait-like characteristics for each caregiver and household. In contrast, for the mobile survey portion of the study, we were trying to capture day-to-day fluctuations within a household or a caregiver, and we included very brief measures of daily food insecurity, caregiver negative affect, caregiver's executive function, parenting practices, and the use of food-based coping strategies. So we'll talk a little bit now about what we found from this. So we obtained a sample of 61 caregivers. Notably, this sample was demographically quite homogeneous in some regards. The vast majority of participants were white females who were caring for a biological child. The sample demonstrated significant food insecurity, and over half of these households fell into that very low food security category, where they endorsed skipping meals and cutting down on the quantity, not just the quality of food. In addition, the sample was well balanced with regard to their participation in SNAP. About half participated in SNAP. However, all families did report receiving some form of food assistance, which included some of these more local initiatives that were developed in response to the pandemic. So it is notable that the caregivers in the study had quite a wide range of educational levels, ranging from having less than a high school diploma to a graduate degree. Household incomes also varied quite widely, from less than $20,000 to over $70,000 a year. And about half of the caregivers did consider themselves to be single parents. Overall, there was nothing particularly concerning about this sample's functioning at baseline. They generally had subclinical levels of mental health symptoms, both the parents and children. They reported, caregivers reported using predominantly positive parenting techniques, and they had sort of expected levels of cognitive functioning. The caregivers engaged really well throughout the study. We only had 3 participants that terminated prior to completing the full 35 days, and the overall rate of survey completion was about 90%, which was quite high. And as you can see, that was really quite stable throughout the weeks of the study. So moving into kind of the specific aims for this study, the first aim was to examine the relationship between household food insecurity and child emotional behavioral problems. Within this aim, I had 2 hypotheses. The first hypothesis was that higher overall levels of food insecurity or more severe food insecurity would be associated with more severe child emotional behavioral problems. The second hypothesis was that higher levels of variability in food insecurity or greater instability from day to day would be associated with more severe child emotional behavioral problems. So to test this, I performed a series of linear regressions with the household's past year level of food insecurity, predicting various domains of the children's emotional behavioral functioning. The results here showed that past year household food insecurity was positively associated with both children's overall level of emotional behavioral problems, as well as with internalizing symptoms specifically. However, past year food insecurity was not associated with children's externalizing problems, attention problems, or their academic performance. And these are just those results presented in numerical format. So for the second hypothesis, we tested whether the amount of day-to-day variability in a household's level of food insecurity over the course of the study was associated with more severe child emotional behavioral problems. We first inspected the data visually, which, as you can see here, confirmed that there was indeed substantial variation in food insecurity from day to day. Here on this graph, each one of these colored lines represents a household's daily rating of food insecurity, which you can see varies substantially. Okay, so what we did next was we quantified the magnitude of that variability by computing a metric called the intra-individual standard deviation. And basically, that just reflects the household's average level of fluctuation from their mean level of food insecurity. We use that in addition to the household's intra-individual mean, which represents the household's average level of food insecurity across all the daily ratings, to simultaneously predict the different domains of child emotional behavioral functioning. And interestingly, what the results showed was that the intra-individual standard deviation but not the intra-individual mean, was positively associated with children's overall level of emotional behavioral problems and internalizing symptoms. This suggests that variability, but not severity, of food insecurity during the study was most predictive of children's emotional behavioral functioning. And again, here are these results just presented in numeric format if you want to look at it that way. Okay, so to recap for specific aim 1, our findings supported the hypothesis that the overall level of food insecurity, as well as the variability in food insecurity, would be associated with child emotional behavioral problems, with some suggestion that variability may actually be the stronger predictor here. So now moving on to my second aim, I sought here to examine daily patterns of covariation between household food insecurity and caregivers' affect, executive functioning, and parenting. The first hypothesis I had associated with this aim was that higher levels of food insecurity would be associated with more caregiver negative affect and executive function difficulty and less positive parenting behaviors. Relatedly, my second hypothesis was that caregiver negative affect and executive function challenges would mediate the relationship between food insecurity and parenting behaviors. So essentially, food insecurity would affect parenting through its effects on caregivers' mood and executive function. Before we could test this question directly, we needed to first examine how well the questions that we were asking every day actually measured the concepts that we were interested in. So to do this, we fit a series of multi-level confirmatory factor analysis models. And so, for example, on the diagram on the right, this shows a multi-level CFA for food insecurity. We ended up retaining 4 items related to food insecurity, which are shown in the square boxes in the middle. And these 4 items reliably measured both between household differences in food insecurity, as well as within household or within person changes in food insecurity from one day to the next. And so we repeated this process for the constructs of caregiver negative affect, caregiver executive functioning, which yielded 2 components, one of effective action, or how much a caregiver perceived themselves to be effective in daily activities, and another component, which was attention or impulse control, and then a parent-child conflict factor. So then we use these factors to examine the relationships among these constructs using a multi-level structural equation model framework in which food insecurity directly predicted caregivers' affect, executive function, and parent-child conflict. And as shown here on the right, the results showed that on any given day, more severe household food insecurity was directly associated with higher levels of caregiver negative affect and decreased perceived effectiveness and ability to control their attention and impulses. So these are shown with the solid lines here. However, as shown with the dotted line, daily food insecurity was not directly associated with greater parent-child conflict. Next, to test whether caregivers' negative affect and executive function mediated the relations between household food insecurity and parenting practices, we simply expanded this multi-level structural equation model to include indirect paths between food insecurity and parent-child conflict via the effects of caregivers' executive function and negative affect. So to display that visually, here the results showed that on any given day, food insecurity was indirectly associated with parent-child conflict through both the caregiver's negative affect, which is shown in this pathway here, as well as through caregivers' attention and impulse control difficulties. All right, and so to summarize AIM 2 findings, we generally did find support for our hypotheses as daily food insecurity was directly associated with more caregiver negative affect and executive function challenges, and indirectly associated with parent-child conflict via negative affect and attentional challenges. Okay, and so for my third and final aim, I sought to examine the type and frequency of strategies that households used to cope with food insecurity and their effects on caregivers' affect and executive function. So based on the existing literature, my first hypothesis was that food-based coping strategies would be used more at the end of the month and by non-participants in the Supplemental Nutrition Assistance Program. And finally, in line with that scarcity mindset model, I hypothesized that the use of food-based coping strategies would be associated with lower food insecurity, so effectively managing that pressing need, but at the cost of having higher caregiver negative affect and executive function difficulties. So for the first aim, overall, what we found was that caregivers frequently used a wide variety of coping strategies. This graph here shows some of the most common strategies that we identified, as well as the percentage of the participants in our sample that reported endorsing these coping strategies on a given week. And so you can see that some strategies are quite high, up to almost 85% of families using them. In general, the most common strategies included buying lower quality food, skipping meals, traveling from store to store, and eating food past the expiration date. The median number of coping strategies used each week was 4. And so families really were kind of creatively cobbling together different ways of managing or acquiring enough food for their family. Interestingly, and contrary to our hypothesis, this did not differ based upon participation in SNAP or the timing within the month. And so finally, I sought to explore the daily impact of using these food-based coping strategies on both the household food insecurity and caregivers' level of negative affect and executive function. So in order to look at this, I expanded upon the multi-level mediation model that I presented previously to create basically this mess of a model, which showed that there was not evidence to support the idea that food-based coping strategies were meeting households' needs at the expense of caregivers' well-being. What we found was that on any given day, using food-based coping strategies was actually associated with more food insecurity and had no impact on hunger or caregivers' affect or executive function. So for AIM 3, neither our hypothesis about who and when food-based coping strategies were used or the effects of food-based coping strategies on the family's functioning were supported. All right, so now to talk about the summary and conclusions from this work. So what I find to be the main takeaways from my project, as well as the extensive literature on food insecurity that we've discussed, is that food insecurity is an incredibly common and intractable problem. And its impact goes far beyond just hunger and nutrition. It has negative effects on the children, their caregivers, and the overall functioning of the family system. It's also important to note that the effects of family dysfunction are likely to have enduring psychological effects, even if the family is able to achieve food security later on. Also, food insecurity is a highly complex construct, and for that reason, a family's level of food insecurity cannot be accurately deduced based on their income, their educational level, their occupation, or their body composition. And while the challenge of food insecurity can feel really overwhelming and daunting, our work suggests that parenting stress and household chaos may be targets that we can support as both mental health and public health professionals. So, as clinicians, the best first step to addressing the mental health impact of food insecurity is probably to ask about it directly. We would recommend the use of brief food insecurity screeners, which I'll show you some on the next slide. And ideally, this assessment would be conducted on more than one occasion, as our findings show that food insecurity can fluctuate significantly within a household. And other research also shows that people tend to underreport their food insecurity when they're asked to report on experiences over a long period of time. Once we've identified that a family struggles with food insecurity, it would be important to ask about their individual experiences, as we can see that it can look incredibly different from one household to the next. And so, for example, you may want to ask the parents about the strategies that they're using to acquire and manage food for their house. What does that look like in terms of their family's daily routine? How do the caregivers feel about having to use those strategies? Are they stressed, ashamed, anxious? With the children, it would be important to try to get a sense of whether and to what extent they may have awareness of their parents' worries about food. How much information are the caregivers sharing with the child about their stressors? And how are the children responding emotionally and behaviorally to that knowledge? Are they feeling anxious? Are they trying to not place an additional burden on their parent? And it also may be helpful to get a sense of whether children are starting to become aware of differences in their families' level of food security and financial security as compared to their peers, and how that might be impacting them. So another important takeaway that has clinical relevance is that we really did see an impressive level of engagement from our families in this study when we made the study entirely remote and helped address barriers to participation. And thinking clinically, this highlights the importance of bringing care directly into these communities through avenues like mobile clinics or telehealth. And as promised, here are some of the very brief validated measures for food insecurity that have been used in various settings. If you can feel free to take a picture of this slide if that's helpful. But some of them are as brief as 2 items and can be administered very quickly. All right. So in terms of policy, our work suggests that programming needs to go beyond simply addressing food insecurity through nutrition. Of course, nutrition is incredibly important, but current data suggests that we're actually doing pretty well in supporting food insecure families in this regard. We now need to look at the more complex, nuanced effects of food insecurity, including parenting stress and household chaos. Potential avenues for addressing these underlying drivers of family dysfunction could include things such as increasing SNAP allotments to help smooth out the availability of funds throughout the month and increase stability and consistency within the household. Also, enhancing the capacity of local food banks or local food assistance programs so that families can have a consistent, reliable source of assistance to turn to, rather than what they are doing currently, which tends to be cobbling together multiple different types of strategies to get by. Also providing families with additional services to support parents, including things like childcare support, transportation support, as well as mental health services. And very briefly, before I open up to questions, I do just want to acknowledge some of the limitations of this study. One of the biggest challenges was that the timing of the data collection was during the COVID-19 pandemic. So participants were being faced with both new forms of stress as well as new forms of support. And that makes it hard to know to what extent that would generalize to other points in time. There is also very limited diversity in our sample, and it makes it unclear how well these findings would generalize to other points and other populations. Daily diary studies in general are also limited in that they use very brief assessments and with the goal of not overburdening participants, and they do tend to rely on a single informant. And from here, I hope to be able to expand this work and examine the effects of daily food insecurity in more urban samples to increase diversity, as well as capture other methods of coping that may not be available to participants in rural areas. I also hope to expand the data collection to include younger and older children, as well as include teacher and children and adolescents input themselves, and ultimately to be able to use this type of daily diary methodology to, in an experimental design, to evaluate the effects of policy changes, such as increasing benefits on family functioning. All right. Thank you so much for listening. I think at this point, I can take any questions.
That was so wonderful. Thank you so much for sharing your research. And we have a couple questions. And yeah, I think this is just so heartbreaking, showing the effect of food insecurity on the mental health of families and how hard parents are working. And then also that we have the tools to address this, but our country's choosing, because of racism and capitalism, to not address food insecurity. And we're continuing to see these effects. So here are some questions. So Natasha said, great talk, Merelise. I'm wondering if you can contextualize these findings in history. Since food insecurity is not new, what explains the current findings? Are we better at identifying mental health and developmental issues? Are parents more stressed than past generations? Or any thoughts on that?
Yeah. So I think that people have been talking about food insecurity and its effects on mental health in kind of in a broad sense for a little while, in that public health, really coming from the public health literature, showing that there is kind of an increased risk. But I think that a lot of where that's kind of where a lot of the literature has stopped, and there's been less of an exploration of what is driving that. And so I also think that a lot of, over time, research has moved away from lumping the all and under like poverty to kind of breaking it out into more specific social conditions. And so I think that that has also allowed for us to be a little bit more refined in how we're examining those associations.
Yeah. Some great questions coming up. So Daisy, you're asking some really great questions. I'm going to try and maybe condense them together. So I think, so Daisy said, although some points brought up are important, shouldn't we focus less on what these families can do, right? These families that are really stressed, already doing all these mechanisms, and more so on government and policy approaches to reduce food insecurities. And also, I think she also, said, it doesn't seem ideal or super realistic to bring up things families can do to cope, which people will lean on and ignore government and policy weight. So I think this is a really important point. These are structural issues that the government needs to address. But I think also what Merelise is bringing up, what can clinicians do when they're seeing patients in these situations? So I think, so I guess the first question is, should we be focusing on what families can do or more on kind of policy?
Yeah. So I love that question too, because I think it is somewhat of a delicate balance. And one thing I think just thinking about how this sample is this is generally a sample that is, functioning well overall. There were not a lot of concerns in this sample. And so I think that helps kind of dissuade potentially that narrative of there, that this is something, a deficit in that these families have by virtue of being low income, that's somehow, a deficit. But I also think, that the policy is where the most change will come. And while that is, we're waiting on that and trying to work on that, we're going to see families that are coming in our clinic. And I think it's best if we can be equipped with understanding how food insecurity might be affecting the child, how food insecurity might be affecting the parent, and how those might be interacting, so that we can try to support them when we're in a situation where these problems have already developed and have already manifested. So I think we need to understand how it's affecting them and try to support them when those problems are already present, and be simultaneously working hard for broader policy change.
I think the slide you showed about the parent coping mechanisms wasn't to show, oh, this is what parents should do. It's like these parents are doing everything they absolutely can. They are amazing parents, trying everything they can with these kind of inequities forced on them. And so this narrative that people say that people need to work harder or spend less, it's just rooted in, it's just kind of oppressionistic talk. But so Ippy had a question. He said, this is such an important topic. Thanks for doing your work and presenting it. Do you have any thoughts on how the new work eligibility restrictions being proposed for SNAP will affect the mental health of children and parents? So he's referring to the recent debt ceiling kind of agreement, which would they increase work eligibility for people from 49 to 54 for SNAP. So, and then how about authoring an op-ed about it, given your expertise and knowledge? That's a great point, Ippy.
Yeah, I mean, I think that, so I like that idea. I think that would be very timely. And, one of the things in this study that was interesting is we didn't actually see the difference between SNAP participants and non-SNAP participants in terms of food insecurity or coping strategy use, which we expected to see based on the previous literature that had been conducted pre-pandemic. And we were looking at SNAP participants who were receiving the maximum allotment at that time due to the kind of temporary emergency expansion of SNAP. And so that kind of suggests that that expansion of SNAP may have really been helping to smooth things out and make that more even in that group. And so I think that there is some evidence to suggest that having increased SNAP allotment is helpful for the mental health of children and parents. And I think, moving away from that in general would probably be harmful.
And I know, and Patty's asked a few questions, so I want to make sure we answer some of them. And this is a really important topic. She asked, what's the best way to ask about food insecurity in a clinical setting? So it's always a difficult subject for clinicians to broach, and many avoid it out of fear of making the patient and family uncomfortable. And then I think the other thing is, do places like UCLA even address food insecurity when you're asking about it? In our VA clinic, we could give out food, or we could, so yeah.
Yeah, I mean, I think that it also, I think that the clinician having discomfort with that also, is something that warrants maybe like exploration of like the clinician's lived experience and bias of why, that may be something that is uncomfortable to bring up. I do think having like the screeners can be a nice start though, to see if kind of triage and see if that is something that warrants for further discussion. But I think that, and this is just sort of my personal style. I don't know that there's like a right or wrong way, but in an intake interview, while I like to kind of gather information on a lot of different identities and experiences, and including socioeconomic, I think just kind of weaving it into that in terms of some of the identities that people hold works well. But I think that, I don't think that it's something that necessarily should make clinicians feel uncomfortable. And I think that reflects probably a bias in the clinician as well, that is important to talk about and address as well.
I think also you can, when you're doing your visit, you could normalize it. Like lots of families are struggling right now with the cost of food, and this can be a stressor for the family, but
yeah. And I think kind of bringing it up as matter of factly as possible too, can and not kind of conveying like, oh, I'm really nervous to ask you this question, can be helpful as well, so that it seems like any other question that you would ask, because we ask our like families really sensitive questions about all sorts of things, and so I don't think that this should be any different.
Any last questions? This is really, really helpful. So I think working on the op-ed, and then I think also what Daisy pointed out, being, when you publish and really kind of not putting it in on the individual level and more of the policy. So yeah. All right. Well, I think we're past the time. So we're so thankful for you for presenting for us today. And I think those screeners you showed will be helpful. And I guess the other thing is for people who are working with patients, the other confusing piece is the food banks are often really confusing. So they often aren't updated, and patients talk about driving around and not being able to find them. So I think we can also work on updating our resources for families and stuff as well. So yeah.
Yeah.
All right. Thank you.
Yeah. And feel free to reach out to me via email if you have any questions that we didn't get to discuss today. Thank you all.
Thank you.